Okay, so welcome everybody to the first meeting of the Math for Public Health colloquium series. My name is Kumar Murty. I'm director of the Fields Institute. I think everyone on this call knows the Fields Institute, but for those who don't know, we're an independent research organization. We have 20 universities in Ontario as members, either principal members or affiliate members. And we work with universities and other research institutes across Canada and around the world as well. Math for Public Health is a new initiative funded recently by the federal government, and it's a consortium of the math research institutes, the Pacific Institute for Mathematical Sciences in Vancouver, the Centre de Recherche Mathématique in Montreal, Fields in Toronto, and the Atlantic Association for Research in Mathematical Sciences in Fredericton. There are about more than 50 researchers involved in the Math for Public Health project. And there's about 12 themes, nearly a dozen themes that are being studied in this project. So as part of this big work, we have a colloquium series so that we can hear ongoing research, both by members of the team as well as from people from outside. And we've scheduled it this year as a colloquium rather than a seminar, so as to make it more accessible. So it's not meant to be technical, it's meant to be accessible, to spread ideas, to get people interested and excited about ideas, and to stimulate conversation. So if you hear something in these talks that you find interesting, you can follow up with the speakers and with others into a more technical discussion. So to kick this off, I'm really delighted to welcome members from the Ministry of Health and the province of Ontario to speak to us about the hurricane model. What is interesting is in this past 18 months or so or more of the pandemic, whereas a lot of people have been involved in making predictions or forecasts about how the pandemic would move, the dynamics of transmission and so on. Some new science has also been created. It's not just using old tools to do predictable models, but new science has also been created. And one of the things that has come out of this work is what we call the hurricane model, which is really disjoint from the compartmental models that are more commonly used. And I think it really adds a new dimension, a new perspective to understanding the dynamics of pandemics. So our first talk is about the hurricane model. And I'm going to turn it over now to Kamil Malikov from Ministry of Health, who will introduce his team who's been thinking about this model and who will present the results. And Kamil, if you would also tell us a little bit about your background and your group's background before you start. Please.
Yeah, sure. Thank you, Dr. Murty, and thank you, Dr. Wu, for inviting us to give this presentation. I'm Kamil Malikov. I'm director of the Health Data Science branch. I'm working with the ministry for about 12, 13 years now, and I started the role in the ministry as a manager of Methods and Modeling Unit, which is now part of the new branch that we created in 2018. And the creation of the branch was sort of caused by the increased use of the evidence based on the predictive analytics, on the advanced analytics, on the models that are developed for forecasting, for scenario planning, and many other reasons. So ministry is using now this predictive analytics, advanced analytics, machine learning and artificial intelligence products for multiple projects and to inform many decisions that ministry, and now it is two ministries, Ministry of Health and Ministry of Long-Term Care, has to make during its regular work. And it was also proved during the COVID pandemic that the modeling work is very important for the decision making also during the infectious disease pandemics and outbreaks. So we started with the focus on three main streams of the work, one of which was the precision population health, and branch was supporting the program areas of the ministry with the descriptive models that estimated the cost of different procedures, the creation of the cohorts for quality-based procedures, which is one of the streams of the funding in the ministry now under the hospital funding reforms, and a few other things. Another stream of work that we're supporting quite heavily is the improving the internal operational procedures, improving efficiency of the, there was a function in the ministry that was looking into the tweets to determine the potential public threats for the province. And we helped them to automate the review of the tweets by creating a artificial intelligence product that screened the tweets and flagged the tweets with potential threats for the province, for the provincial public care, for the further review by the experts in the public health field. That helped to save quite a good amount of the work hours, which was assigned for more meaningful tasks. We're also working on automating and the screening of the complaints about the long-term care facilities to streamline the risk application for planning the next stream of the inspections in the long-term care facilities. And the final stream of work is the anomaly detection, which helps the ministry with the accountability function by reviewing the fee-based services that ministry supports, including the drugs that are provided to senior population and a few other groups of population free of charge, by also reviewing the assistive device programs that some of the people in Ontario are eligible to receive free of charge from the province or partially paid by the province of Ontario. And as you can understand, the COVID also added quite a bit of work on to our plate. We had a very short timelines to learn about using the models and types of models that are used for infectious disease forecasting and modeling. And what helps a lot is that we were part of the important independent bodies that was created by the scientists and academicians in Ontario, including the Science Advisory Table and Modeling Consensus Table. We learned a lot from these experts. And the work that the team will be presenting is also a result of our learning from the Modeling Consensus Table from one of the presentations. More details will be given by our main presenter, Feaven Sahle, who is the senior methodologist with the Cognitive Analytics Unit. Feaven, can you sort of make a sign so that people know you?
Hello, hi.
And she worked with Peter Hamilton, who is the senior visual analytical developer in the branch. Peter, may sort of see you making, so we see Peter too. And hello. And Peter has a very important role in the branch because a lot of the models that we're developing, a lot of messages that we're developing are very technical in nature, and they require a good visualization for the policymakers to understand and start using the results of the predictive analytics and advanced analytics products. And I also want to introduce Saad Reis, who is the manager in the branch, and he was also key in transitioning the knowledge from MCT and helping with establishing this methodology and adapting this methodology in the branch. With that, I will pass the floor to Feaven and wish her good luck.
Thank you, Kamil. Give me one moment to share my screen. Can you guys see it okay?
Yes, we can.
Okay, great. Thanks, Kamil, for the introduction, and thanks everyone for taking their time, especially after a long weekend this afternoon, to be with us today. As well as I want to further extend the thanks to Fields Institute for the invitation to be here. So today we're going to talk about the hurricane model in the context of public health. We're going to talk about the method itself, so its methodology, the use, and as well as the contribution, which is the animation. It was mentioned in the invitation, but just to review the abstract. So hurricane models are more familiar to the world of finance for forecasting financial indicators. The methodology was led by a team with Taha and Kumar from Fields Institute and University of Toronto. And that was mentioned as well. So I'm very glad that Taha and Kumar are here with us as well. So we started the use of these types of models in public health, as Kamil mentioned, during COVID. And there was an initial presentation to us of the concept by Taha earlier this year, as well as further research carried out by Fields University of Toronto group. So here we'll present the concept, the method, as well as some preliminary results, and present as well an animation, which is our contribution to the application of this concept. So the term hurricane and hurricane methodology, it's meant to reflect a cyclical nature of case trends with transitions between 4 quadrants. We'll talk a little bit more about these 4 quadrants later and what we mean by growth and change in growth, but the definition for the 4 are early warning signs, hotspots, cooling down, and managing. And for our purposes, we're going to look at Ontario. So the hurricane model forecasts a given study region, in our case, Ontario. And we take a look at the case growth rate at a given time and a change in case growth rate, what we call acceleration, from other reference jurisdictions that have experienced the same growth rate and acceleration. So that can be broken down to 2 different steps. First, finding the current growth rate and acceleration in the study region. As I mentioned, we'll be looking at Ontario. And you search across other jurisdictions for the same growth rate and acceleration. So subsequent growth and acceleration trends from those jurisdictions identified are then projected onto the study region of interest, Ontario. So we use data from around 300 jurisdictions, resulting in 300 case forecasts for Ontario, and visually looking at it as a 10th, 25th, 50th, 75th, and 90th percentiles. And this methodology is more of a comparison to other jurisdictions tracking against the forecast percentiles. So a background and summary of how we applied this method. So as mentioned, there's about 300 forecasts of cases. And we first took a look at wave 3, seeing where do we track against the percentiles from a wave that's already passed. And then while refreshing and preparing for this presentation, we started as well with the beginning of wave 4, which is agreed upon by most researchers in public health units to be the beginning of August. So these forecasts were produced by drawing on the data from the jurisdictions mentioned, and Ontario's actual case trends were compared against the forecasts for both wave 3 and now the beginning of wave 4. And some preliminary results of what we saw was that wave 3 was significantly higher than the median forecasted case trend out of all the forecasts generated. And wave 4 showed the actual case trend is lower than the median. This trend could reflect the impact of vaccinations, provincial lockdowns, continued use of PPE, social distancing, etc. So when we talk about Ontario's growth and acceleration, these 2 plots kind of demonstrate what that looks like and what that means. So the first chart above is the weekly growth rate over time. And so we refreshed the analysis previously done and shared with us by Taha to include up to August 31st. And we can see Ontario's weekly growth rate. And then the second one, likewise, up to the end of August. And this kind of can show you visually the waves. So we can see, for instance, in March of 2021, the increase in growth rate of COVID cases. Likewise, we could see in the chart below March of 2021, the positive acceleration in time. And as we hit the second half of the wave, we can see the deceleration and the negative weekly growth rates, change in weekly growth rates, up to now where we have now a positive acceleration as well as increasing in weekly growth rates over time. Okay, so before we go towards the animation, a little bit more about what we spoke about in the initial slides of these 4 quadrants and this idea of a cyclical nature of COVID cases. So here we have on the x-axis, the weekly growth rate, and the y-axis, we have change in weekly growth rate, otherwise known as the acceleration. And we can see these 4 quadrants defined in different colors as well as labeled here. So we have early warning signs, which is positive acceleration and growth here in yellow. And then we have hotspots, which is also positive weekly growth rates. However, it's on the right side of this vertical line. And how this vertical line is defined is the global rate. So this global rate was calculated, I think, in January of this year. So it's 0.05 here. And so positive acceleration with the weekly rate above the global rate is how this hotspot is defined. And as we go down to cooling down, it's deceleration and growth. However, it's still above the global rate. And then back to white, which is managing, which is below the weekly growth rate, the global weekly growth rate, as well as negative weekly change in weekly growth rate, so decelerating still. And here we have, it's a snapshot of June 21st, 2020. And so we plotted Ontario in blue, but we also included public health units for the purposes of visualization. And we have a couple here. So red is Toronto, orange Halton, green Peel, York purple, and City of Ottawa black. And so just for demonstration purposes, we've included additional granularity of data. And also the time frame is just denoted at the top right, just in case it wasn't clear before. And before we go to the animation itself, and I can hand it off to Peter to speak further about it before I press play. The time frame is on the right-hand side, as well as there's a timeline at the bottom, which also will denote the starts of the different waves. So we can follow along both through the time at the top right, as well as the timeline at the bottom. And we're gonna follow along the different areas along in the visualization here. Peter, do you wanna say anything before I press play?
Yeah, sure. Just a couple things to note. So along the bottom there, we have annotations of when the different waves start. So you can see W2, W3, W4. So that's wave 2, 3, 4. Wave 1 starts outside of the time frame because this animation is between June 2020 and now. And then also while you're watching it, you'll notice trails leading behind all of the public health unit circles. So that's just to give an idea of the last 20-day trend of that public health unit. So it's a window of the activity of that public health unit. I believe that's all really to mention. I guess other than that, it was made with matplotlib and a small animation library that we developed on top of that. So that's all.
Thank you, Peter. I do see a hand up.
Yeah. Can I ask a question?
I think so, yeah.
Okay, so just maybe you mentioned this already and I missed it, but why is the growth rate never negative on your scale here?
So it's why is the growth rate never negative? Actually, I think it's in absolute terms, but if anyone else has, I believe it's in absolute terms for the growth rate, and then the acceleration is the only one denoted as positive and negative.
Right, the growth rate measures the daily cases. So it's the derivative, its growth is derivative of the total number of cases, and therefore it cannot be negative.
Thank you, Taha.
Oh, I see, the cumulative total number. Got
That's
it. Okay, thanks.
Yes, it's cumulative number.
Thank you. Okay, so I'm gonna press play, and we can see at the bottom the timeline, with the exception of Ottawa, which has already done a loop. The rest of them are around early warning signs, and then we can see the beginning of wave 2, and it oscillates between hotspots and cooling down. And then we're back to managing with the exception of Ottawa again. And you can see as the new year begins and vaccination efforts ramp up for senior populations, we were in managing. However, the wave 3 begins before non-senior populations. And here in the end of the beginning of the summer, we're around managing to early warning signs, which is where we land off in early warning signs in the beginning of September. I'm just going to run it one more time. So that's the animation. One thing to note is the actual vertical line hasn't been updated since January, so that could change as we move further into the pandemic.
And maybe, Feaven, if you allow me,
yes, of
the
course.
unusual behavior of the city of Ottawa is in the wave 2 is probably can be explained by the fact that the city of Ottawa noticed the signals of the warming up quite early and started the measures to restrict the spread of the infection early in the wave 2. And that's why they had the full circle before entering the second circle of hotspot cooling down and managing with the rest of the province, simply because they travel across the province and from Quebec to Ontario was not restricted. And that's probably one of the explanations of why the city of Ottawa had an extra cycle compared to the rest of the province and the other PHUs.
Thank you, Kamil. And we can see at the end of the animation that all of the regions are around early warning signs. Okay. So just to continue with the refresh of the analysis and concept, going over what we mean by all the paths for Ontario. So these represents all the different possible acceleration growths, starting at the beginning of wave 4, doing the jurisdictional scan of all case trends. Another way to look at it is just through opacity. So the saturated points are most of the case trends, and then we can see all the others as well. And as this is a little difficult to kind of piece together. There's also later on we'll go through percentiles further, but just to introduce it in terms of growth and acceleration, we can see the same chart as we saw earlier. However, we've added the percentiles to it as well. And we can see the growth percentile trends as well as the acceleration percentile trends with negative acceleration for the 10th percentile below. Okay, and so the actual methodology, and earlier was mentioned as well, looks at the actual percentiles in comparison with Ontario's case projections. So here we're going to look at the Wave 360-day comparison. So all the possible forecasts are generated via the hurricane model, and we can see that we're trending towards closely with the 75th percentile line. This indicates that Ontario's case trends are higher than the median cases observed in other jurisdictions. And this is just for the 60th days. And as we continue further on, so 120-day comparison, it tapers down from the 50th percentile line closer towards the 50th percentile line, which possibly could reflect the impact of provincial lockdowns, vaccination efforts, continued use of PPE as well as social distancing. And as we mentioned earlier, we did a refresh of the analysis for post-Wave 3, so beginning of Wave 4 is later on, but after May 1st to see where we landed after May 1st. So it tapered further from the 50th percentile line, as we can see here, closer towards the 10th and 25th, in between the 10th and 25th percentile. And again, post-Wave 3, however, looking at the beginning of August, we can see that we can continue between the 25th and 10th percentile lines. It looks like here we're closer towards the 25th, meaning that Ontario's cases are lower than the median cases observed in other jurisdictions. So in summary, the methodology was helpful as a tool for comparison to other jurisdictions by way of tracking against these forecast percentiles, as well as useful for projections, possible projections. The results for Wave 3 showed that Ontario's cases were significantly higher than the median forecasted case trend out of the forecasts generated. And for Wave 4, the actual case trend is lower than the median, tracking closely along the 25th percentile line. And as mentioned earlier, this could be the impact of vaccinations and provincial lockdowns. And the team, as Kamil mentioned, will continue to use methodology as an additional data point in our analysis, as well as for planning efforts and recommendations, as well as potential as an instrument for future analysis and other potential applications. And note on the data, so for presentation purposes for Ontario, we stuck with Johns Hopkins data, and the case data for Ontario was public health units is from IFIS/CCM. And yeah, that's the presentation. If I missed anything, Kamil or Peter, feel free to, or Sad, Taha, feel free to add as well. And that's an introduction to our use of the hurricane model as well as the animation.
Thank you, Feaven. So we are ahead of the given to us time, but we're ready to answer any questions you may have. And if required, we may ask for help from Taha and Dr. Murty.
Maybe I can start with questions, Jianhong. Are you think about using this again in your final slide? Feeling you mentioned you explore other applications. Are you think about explore this for influenza?
We don't know about the future yet, We've never been involved in the infectious disease modeling before COVID. So it's some sort of area that I don't think that anybody in the province were doing modeling for the purposes of government policy development. I know that Dr. Wu, you are involved heavily in the modeling for the infectious diseases for the academic purpose, for the research purposes. But for the government, so far, the only focus on the infectious disease analytics was the surveillance and the descriptive analytics of the cases, number of cases. But it looks like learning from the COVID pandemic, there is an interest both in the Public Health Ontario and the Chief Medical Officer of Health of Ontario, new Chief Medical Officer of Health in Ontario, to have these functions preserved and extended. And since we gained so much experience and learned so much from experts in the modeling consensus table, we will be able to continue providing this support to the Chief Medical Officer of Health and Public Health Ontario if required. So we didn't think very closely about applying this to influenza, but we definitely can. That's a little bit long-winded answer to your question.
Thank you, Kamil. I just was wondering, this year, I think influenza might be important issue. Last year was lucky because we had a vaccine, intensive vaccine campaign in the summer to urge citizens to take flu vaccine. This year we could not do it because we are focused on COVID-19, and so the flu might be, I mean, although our focus is still on COVID-19, but I feel tracking the flu will be very important to really to not confuse with the COVID-19. That's why, and I think the technology could be adopted relatively quickly.
Yes, and this gives a very good also ability to track the performance of the province against the other jurisdictions by creating the frontier of possibilities from the experiences of other jurisdictions who are ahead of the province in terms of any contagious disease, including influenza, and then see what additional public health measures are required to put in place to move the actuals closer to the best case scenario compared to the middle or worst case scenario.
Thank you. Kumar raised their hand, so maybe Kumar, you want to answer the question or raise the question?
No, I want to ask it. No, not really ask the question. First, I wanted to appreciate the presentation. It's a very nice presentation, and I'm really delighted that people in Ministry of Health are working with this tool. There's more to be done. There's a lot more to be done, even with the data that we have now. So, for example, Kamil, you started to explain the behavior of Ottawa in that dynamic, but there's more to analyze there in the dynamic between communities, because you might want to look at other instances where we have enough data to track that and say, look, this is something we can predict. If something happens here, this is what's going to happen there. So that kind of knowledge of the connectedness, of the dynamics is going to be really useful for planning people, for those who are involved in health planning. Secondly, it's odd that you say in various government agencies there wasn't modeling going on, but I hope the pandemic has taught us the importance of this. And in any case, I think it has definitely taught us the importance of the collaboration between the academics and government ministries, both at the provincial and the federal level. I know John Hong has been heavily involved at both levels, and I think it has definitely informed those who consider the implications of the models and what they're predicting. About applying this for flu, you need one thing that makes hurricane work well is that you have tons of data. You're tracking this, it's a pandemic, so you've got data from all over the world. You have enough jurisdictions, you have enough data. A question that one has to think about is, in a particular instance, if you're tracking something more localized, if you have enough data streams to form the model. So that's something to think about. Maybe Taha I think has thought a lot about this. He might have something more to say. But all on the whole, I just wanted to say it's a really good presentation. I'm looking forward to more collaboration with you guys, because I think there are a ton of questions that need to be asked and answered still on this model.
Yes, definitely. And thank you, Dr. Murty, for inviting us to be part of the continuous research that you will be doing on this methodology. We will appreciate learning more from you and your team as we go on. We're not an academic institution, we're practical users of the methodology to inform the policymakers, and your advanced research in the new techniques will help us to stay abreast of the developments in the field.
Thank you, Kamil. I think Michael Wolfson, I'm sorry, I noticed you raised your hand.
Hello, thank you very much for the presentation. A couple of questions. The 313 or so data sets that you grabbed from Johns Hopkins, did you think at all about whether they're, it looks like you assume they're all of equal quality, but I would guess that they're not. So, you know, how would the animation look if you selected or stratified the 313 by the, you know, some sense of equality? The other thought that occurs to me, or question, is, you know, some trajectories are going in those 313 are going to look better. I guess they'll be the 10th or 25th percentile rather than the 75th. Have you thought about looking at some of the covariates, like this stringency index that some group in England puts together, to see whether there are any lessons to be learned in addition to where Ontario fits relative to those other jurisdictions? Thanks.
Go ahead, Feaven.
Kamil, you can go ahead. I just want to mention that it was Johns Hopkins plus public health units included in the 313. In terms of data quality and assessing the how well data is reported, there was no checks done prior to see if the data was well reported or not. But Kamil, you can continue. Sorry, I interrupted.
No, you didn't interrupt. I just wanted to say approximately the same. We didn't penalize for the data quality. Neither did we have a lot of additional information to use as a covariates in this modeling exercise. The only data that was available to us came from the Johns Hopkins, and we used whatever was available. But I completely agree with you, Michael, that looking into the jurisdictions selected by the data quality, by the by use of the similar public health measures as Ontario is using, by many other factors like similarity in the population, similarity in the age distribution of the population, might be a good extension of the overall methodology. Unfortunately, we didn't do that. We assumed that the data quality issues will be sort of balanced by the data quality moving in different directions. But I agree that that in the future that will be important.
Could I just add here, Michael, that what you point out is exactly, it is an important point about the purity of the data. But besides that, the other indices, Taha, you can say more about this, but we had a bunch of people looking at adding various things like stringency index to this. We didn't get any conclusive results from that, so that work is still in sort of the initial stages. Taha, did you want to say something more about this?
I can say a few things, not just for this, but also for the previous question as well. In the case of things like stringency, we found that adding it to each of the time series is yet another feature that pulls things apart, actually seems to add some value. Like you end up in this large stream of time series that we're looking at. What it does do is allows us to focus in on time series that, aside from the acceleration and velocity, look more like the policy response is similar as well. The challenge was that the sample size of the possible path forward gets smaller. So what we ended up seeing was a better way of explaining what certain jurisdictions might look like that are similar based on stringency. But because we lost those other time series from it, the amount of sample we have to project that cone of possibilities was hampered. But again, we tried a whole bunch of things to see if we could come around that. Even in the case of looking at the covariance between the individual points here, we ended up looking at a large graph of places across the globe, because the original hurricane model that we had built was really one looking at the entire globe. And we did find that there were differences in the way the covariances played out, how you would measure the covariances between things, between jurisdictions as you're moving along. We never got to the point where we were able to fully pull it out as yet another feature that we could inform things with. The original goal of this project in Scotia was to create an early warning signal. So we ended up finding that just the measures of covariance were very noisy as well. So it goes back to the question of the purity of the data and how good it is to how usable it is in this fashion to get to these points. But again, ultimately, the nature of the work is in a percentile basis, so that some of that noise is getting smoothed over just by the way we're constructing it. But yeah, we did try. I think we're still trying not only different types of time series, different types of features, but different ways of adding them together to build this in some fashion to make it even more rich. One thing I will say, and I don't know if Kumar, you asked the question, but it was about using this for other diseases and other things as a general tool. We've been toying with a crazy idea of using the hurricane projections as a universal forecaster for anything, any kind of outbreak of any kind. And we found some pretty interesting results looking at the historical Ebola cases and a bunch of others that look like you would scratch your head and say, well, I don't understand how a COVID-based projection like this can help us with Ebola, but we're scratching and saying, well, actually, that looks pretty good. So, it could be luck, it could be skill, but we're seeing it across the board for other data sets that we've been looking at that are not necessarily, coronavirus-like, that it seems like it works. And again, the thesis I have on the table right now is that what we're generally looking at here is not just the function of a virus that's spreading across a population, but you're seeing a disease spreading across a whole host of policy responses, a whole host of ways of people interacting. As much as these time series are about the virus moving, it's really about us responding to it. And so these hurricane paths really are a reflection of society's changing way of looking at and dealing with these things. So maybe there's a much more universal usage of this thing that I don't think Kumar and I originally thought of when we were putting it together. We were just looking for a complementary process to go, against some of the time series models and the compartmental models to provide a different point in the triangle of looking at this. But it's pretty interesting. When we get to it, I think in the next little bit, I think everybody will be quite surprised and probably quite skeptical at the results, but it seems to be there.
Yeah, just to add to Taha, I think what you said, it is, at some level, it's an abstract method. It can be almost agnostic to the source of the data. And as you say, it indicates certain dynamics and the way those dynamics react to interventions, even though we can't pinpoint exactly it's this intervention that resulted to that dynamic. And also it's interesting that when you look at daily cases, but when you look at cumulative cases, how closely it does follow a particular percentile. It's pretty amazing when you look at the total number of cases. So something is going on here that is real.
If I can add another thought, though, I wonder, it would be interesting if you had not only all the regions in Ontario, but in other provinces as well. And one could look at the trajectories and compare the stringency or the lockdowns, not only across provinces, but across municipalities. But the other thing is the extent to which people move between health regions. You could see how much diffusion or coupling there is between the trajectories of each health region.
So, Mike, sorry, go ahead, Dan.
Yeah, no, absolutely, absolutely. Definitely, when we look at the stringency indices as an example, we find them to be more reactive as opposed to predictive. You know, things have to happen first, and then policy changes and things start happening. But we found alternative measures of things, you know, like just, you know, usage of subways in Toronto as an example, just to give another way of thinking about how stringency could go along, like people just simply not going on to public transit. And again, in every single case, and again, like I said, I work at Scotia, so we're also looking at people paying their bills. We look at money moving across borders. And in every single case, we found that every alternative measure of stringency we could create was always reactive. So people are not curbing their appetite ahead of a danger, you know, where that's what I was looking for. I was thinking like you, Mike, like, maybe somebody in here is quite smart and knows to stop, and maybe that will use that as an early warning sign. But pretty much as an aggregate, the population simply reacts. So this tool seemed to get us ahead of things because it was looking across the region for things that would then potentially happen. So I think that's where a lot of the value came from. Sorry, Kumar, I didn't mean to interrupt.
No, it's okay. I was just going to add that, Michael, we do have plots for other provinces. We didn't go drill down to comparing PHU levels, but we did graph the dynamics. We made a movie like these guys did for the different provinces in Canada. We also made a movie for the different states of India, and it's a really fascinating movie where you can see the first wave grow, you can see the first wave completely die, and then the second wave start. And I was showing to somebody a little earlier today, examining that movie, it seems to me it unearths potentially some causes for the second wave. So these movies are not only fun to make and watch, but they're also could be quite informative for the dynamics of the disease.
I have two people raise their hand, but I also have my own questions. Maybe I take advantage of this to continue the question for Taha. So I just feel if you have done any time series clustering analysis among the 25 percentile or 55 percentile, so you really can find the characteristics why those curves are in that category and why Ontario, for example, moved from 75 percentile to 50 and to 25. So there must be some features in many of those clusters. So I just wonder if I've done any time series clustering analysis about this.
We've done some work on the time series work, right? So we'll be looking at the intervariance between the two different things that are going, the series of jurisdictions we're looking at. Again, the problem is that cluster analysis is even more beset by the noise. So if even the little bit of choppy, and you know, all this data is quite choppy, you end up getting things that you don't know if it's noise that you're looking at or it's something real. We've tried it. We can definitely sit down with you and walk through some of that so that we can get some ideas if there's something there. But the noisiness of it seems to cloud the information content. And then again, ultimately, then the variance just follows. Like then you have to window the entire thing and slow it down. And you end up getting that something that looks reactive as opposed to predictive. I don't know if that answers the question, but it's a challenge when you start doing derivatives on top of these things, especially with the data that we have.
May I also add, based on my experience from the forecasting for COVID, the policymakers not interested not so much in the forecast itself as much as how close to the worst case or best case scenario we are following to make further changes to the public health measures, non-medical public health measures, to bring the actual trajectory closer to the best case scenario. That was the case with the forecast that we have developed for the long-term care outbreaks and cases The same is with the community-based forecasts that we're making. So what gives the more arguments and more power to policymakers is to demonstrate or to be convinced that the public health measures that they're introducing are changing the curve closer to the stable, closer to the best case scenario, rather than having the actual correct, accurate numbers of the forecast. That's my experience, and I think that the tool, of course, it requires more work to make it more applicable from the academic point of view, but from the practical point of view, it already achieves what is important for the policymakers. Sorry for interruption.
No, thank you. That's exactly the answer I'm looking for. Because there is one very brilliant undergraduate student group actually work at 8 fields in the undergraduate summer research program. They did some analysis about the information progression on the social network. They analyze a bunch of news and look at the clicking through time series, and they did exactly classification in terms of different percentiles, and it's coming to Kamil's point a bit how you can avoid the worst case scenario, the 75 percentile scenario, and move on to the 25%. And so this time series clustering actually might allow you to do some of the analysis to really see how you can avoid the worst case, and what is characteristics of those people moving, get into the worst case scenario, what's characteristic for them to really moving to stay in the best case scenario. So I'll be happy to send you those students' paper to you and see how. And unfortunately, all the students have gone to different places, and but they are from the Fields Institute. Tom already have a question.
Thank you, Jianhong. No, I was just wondering about the jurisdictions and how they relate one to the other. Let me just, I noticed you marked the Canadian data as you could pick out the date that the second wave started, the third wave, the fourth wave. So I'm wondering how the timing between jurisdictions might be related. So I understood from what you said is you look for jurisdictions where their wave 2 could be used to predict our wave 2. So in other words, those were in advance of us, but what about the countries that might have been delayed with respect to Ontario? Did you look at those jurisdictions as well? And how many jurisdictions are there globally that would be, accessible to your analysis? So I'd like to look at all the jurisdictions and then look at the timing of these different waves in the different jurisdictions and see how it relates to how connected geographically these jurisdictions are.
So to the point of like a kind of where Ontario is at a given point, it's less so for like Italy is in their second wave or third wave. It's more of, is there any point where Italy has had that same growth rate and acceleration rate, and where did their growth and acceleration go to? There's less kind of us informing whether it is prior to like their second or third wave, and more of did they hit the criteria of the same growth and acceleration, and then as we plot all the paths, all the forecasts to Ontario accordingly, it's just smoothed out to percentiles following that. I don't think we've done any analysis and on the proximity of those jurisdictions, like do they relate closely just spatially to Ontario or public health units as it's in itself, but that'd be something that'd be interesting to look at as a geospatial visualization to see what that looks like at each point in time where we start to do the forecast.
So really the timing of these was kind of not part of the analysis, and you focus strictly on similar trajectories that happen anytime rather than any specific times. So yeah, but maybe the whole methodology could be extended in scope to look more at the timing of these phases that seem to be important.
I think that's a really good idea. We've seen, like, I think with the Delta variant, when it started up in India and started to then spread across part of the Asian Rim and parts of Africa, you could see it. You couldn't quantify it because I wasn't paying attention to it, but you could definitely see that timing impact that you're describing, literally like a ripple moving across that part of the world when we're looking at it geospatially. So there's definitely something there, not only to the idea, Tom, but also to the way you're thinking about looking at it, Feaven. It's definitely there. I didn't know how to quantify it, or I would have brought it forward for you guys to see.
So could I just ask simply, the 313 jurisdictions are a bit vague to me. Are they covering a large fraction of the population globally, or a small fraction? Roughly speaking, what's the average size of these jurisdictions?
So it's John Hopkins data. So it could be, some of them are sub-national, some of them are national. It's I couldn't off the top of my head quantify what percentage of the population it covers, or the density of coverage by subnational level. But I do, like, as you mentioned, Taha, as well, and the idea of having a geospatial analysis, I think, would be very valuable, to your point, Tom.
Well, on top of what Feaven said, since the 313 countries cover US, Europe, China, India, I would say that the size of the population is big, and it covers majority, if not all, the population. Maybe some smaller jurisdictions are left out because the reporting from them would not make different impact on the forecast. I think it's acceptable that there are some missing jurisdictions.
And I suspect the only subnational ones are the states in the United States and provinces in Canada. Is that right, Taha?
For us, it was the states, the provinces. It was the areas in India. I believe the provinces in China, and I think Britain or the UK had published theirs also very much jurisdictionally, like as a spread out. So wherever we could get it that much detailed, we tried. But many countries weren't putting it out, so we couldn't find, say, for example, the Russian, similar thing from the Russian side, where, you know, there are many sub-jurisdictions in there. And then many cases, the data isn't necessarily fresh either, right? They come at different rates. So the Johns Hopkins data set is probably one of the best ones. And I think that's the one is as considered the gold standard for reporting the COVID numbers.
Mm-hmm. But I am aware of our researcher is probably not very well known, but I happened to hear his talk, and he has exactly this kind of cumulative and daily case data, but at the what's called NUTS 3 level in Europe, which is a very fine scale. So he has jurisdictions, you know, the size of counties in Ontario, and for all of Europe, and it sort of would be fascinating. So way more than 300, I mean, thousands, I think.
We need to collaborate.
I think we need to run instead of colloquially, but probably a workshop. One way I think we can do is really integrate the compartment model, agent-based simulation to generate this data. Maybe you can generate higher quality data than Johns Hopkins
simulated.
You simulated, but those are based on your knowledge, your scenarios that you can imagine in the generate.
Yeah, I agree. There's a lot of scope for work here. Really interesting work.
But may I also add, I don't feel that having the more granular jurisdictions will add to the quality of the forecast, because at the smaller jurisdictions, the changes in the cases will be more of a subject of the random fluctuation rather than some really solid trend that should be taken into account. Again, there should be a balance between the size of the jurisdiction and size of the population that gives the steady statistically approve or valid numbers in change of the cases rather than the subject to the random fluctuations.
Thank you, Kamil. So Kumar, so so I really want to thank the Ministry of Health team for coming and in particular for leaving some time for the discussion. I think this is a very helpful discussion. Really bring all the participants together. So we'll continue, and I hope to be able to get your team constantly coming to fill through the network and to this colloquium. So with that, again, thank you again for the minister team and for all of you for attending today.
Thank you. Thank you for inviting us, and thank you for all the interesting questions and suggestions. They're mostly for Taha and Dr. Murty, but we will be benefiting from their solid research into this issue.
Thanks, everybody. Bye.
Thank